Morning all. So we all know that biliary complication remains a major source of morbidity and mortality in liver transplant patients, with incidence ranging from 10 to 15% in diseased donor transplant, while living donor liver transplants have even higher risk, reaching up to 30%. And this is the one of the recent data from Transplant Society. So what are the causes for what are the biliary complications which we see? So the most common post-liver transplant biliary complications include bile leaks, which is the most common, followed by it comes along with bilomas. Then there is anastomotic strictures, which may be secondary to bile leak or primary stricture leading to bile leak and bilomas, and there may be a non-anastomotic strictures. Then further in late stages we may have bile duct stones, bile casts, and then there is a entity sphincter of Oddi dysfunction, though people say it's less as per the literature. But if you ask me, in my personal experience, I find that sphincter of Oddi dysfunction is one of the important determinant for the outcome of strictures, because many times even if we find radiologically or on ERCP the stricture is gone, and still the patient keeps on getting cholangitis, and even after good EPT, we find that the sphincter is very tight, and that becomes the second point of stenosis, and it doesn't let the free flow of bile. So sphincter of Oddi dysfunction is definitely there. May not be documented, but yes, it persists. So the prompt recognition and treatment of biliary complication reduces the morbidity and mortality and improves graft survival. Else we are going to lose the graft. And as Dr. Vikrant showed that in pediatric population there may be 3 transplant, 4 transplants, though case reports, it is very difficult to get a second transplant in Indian setup. This is what we know and what we have seen. So definitely we need to save the graft, the one graft that is the most precious, and probably the patient won't be able to get a second graft. So bile leak, I'll start with bile leak, and it can be divided into 2, that is early and late. In fact, all the complications are divided into early and late. Whichever happens within 4 weeks of transplant is labeled as early, and which happens after 4 weeks of transplant is labeled as a late leak or a stricture. And bile leaks can be further subclassified as anastomotic or a non-anastomotic. It may be from cut surface or it may be from the anastomotic site. Early bile leaks most commonly occur at the anastomotic site, with ischemia being the important mechanism. And whether there is a stricture or no stricture, it is debatable, but if you do a MRCP, you will definitely see a segment loss. You will find a small segment missing, and which will be reported as a stricture. And finally, when you do a ERCP or PTBD, you will find that there is some resistance, and probably which signifies an area of stenosis at the level of anastomosis. Early bile leaks, LD requires donor hilum dissection and dissection of the recipient bile duct. These maneuvers can result in biliary devascularization and increases ischemia time. And this ischemia, the devascularization of bile duct, is one of the important determinant. And not only the devascularization, there is denervation as well, which leads to dilatation of the duct, and that becomes the reservoir. So that is one of the important thing which we always see, that in a post-transplant setting, the bile duct is dilated, and when we do a MRCP, we find that intrahepatic biliary radicals are absolutely fine, but the CBD is dilated. So it is mostly because of denervation of the CBD, which leads to that CBD acting as a reservoir, and it keeps on containing the bile for a longer time, and may be a source of cholangitis in such patients. So once a bile leak is determined, the type of intervention depends on the anatomy and allowing the access to the biliary tree. So first would be draining the bile leak. So if there is a collection or a biloma, that needs to be first drained. After you drain that, in a duct-to-duct anastomosis, ERCP is the first line of intervention, because there it is good for the patient, more so safe procedure, where you are going from the lumen and directly trying to establish the communication and giving the outflow. For smaller leaks, sphincterotomy alone is sufficient, and stents are often used for larger leaks. And PTBD remains other viable option in a setting of major bile leak, which is not controlled by ERCP or where ERCP is not possible. And surgery is largely reserved for large leaks or leaks presumed secondary to ischemia that are unlikely to improve with stenting or percutaneous drainage. So this is one of the picture from our patient. You can see this is how it is a very early leak, just happening within 2 weeks of transplant. You can see this segment missing. So this is what I was talking about, that you don't find segments. So from this point, the anastomotic site, almost a centimeter, you don't see a duct. Then you see a CBD coming down. You see a collection at the cut surface. This is the cut surface. You see a collection over here. And it is in a subhepatic space, you see a collection. So first would be draining the collection, because that will be the site of infection. Once you drain it, then you need to reestablish the biliary outflow by putting a stent. It may be via ERCP or by PTBD. This is another case where you can see how it happens. So there is a bile leak. You can see this is a bile leak from the anastomotic site and biliary dilatation. This is a good biliary dilatation. Generally, we don't find such a nice biliary dilatation in post-transplant setting, and it is minimal biliary dilatation what we see. So how we start? First, a drain is put on ultrasound guidance, and you can see this is the cut surface, and along the cut surface there was a collection in which the drain has been placed, and thereafter percutaneous biliary drainage has been attempted. And with it, then we try to document the leak. And if you see this image here, there are two leaks, one leak over here, the other leak over here. So you can see the bile freely, and this segment is stenotic. If you see, this is the CBD, this is the duct, whereas this is the segment which is not dilated. So definitely there is a stricture and a leak. So what we need to do, we need to actually first make it a controlled fistula. Once we are draining it externally, then the healing happens at the level of leak, and after that the stricture dilatation is done. And once it is done, it may be done percutaneously, or a rendezvous procedure may be done where ERCP stent may be placed next to PTBD. Moving next to strictures without leak. So up to 50% of post liver transplant biliary complication consists of biliary stricture. So rest all complications consist of 50%, whereas only biliary stricture would account for 50% of the patients. They are divided into two major morphological types, again, that is anastomotic and non-anastomotic. Anastomotic strictures are more common than non-anastomotic, because non-anastomotic strictures have different pathophysiology, and I won't be discussing that. So anastomotic strictures are short, single narrowing, located at the anastomotic site, and they occur mostly within 1 year of the liver transplant, and the mean time of presentation is 5 to 8 weeks. And the most common factors associated with anastomotic strictures are surgical issues over the first months and ischemia leading to fibrous healing at later stages. And additionally, ABO incompatibility, advanced recipient age, small bile duct caliber, prolonged warm and cold ischemia time, and CMV infections are reported to be significant risk factors for anastomotic strictures. So as per the literature, ERCP is the standard of care for the treatment of anastomotic strictures wherever anatomy allows it. The overall reported success rate ranges from 70 to 100%, and for patients with altered or complex anatomy or hepaticojejunostomy, PTVD is the widely accepted approach. Surgical therapy is mostly used for salvage therapy upon the failure of ERCP or PTBD. PTBD further remains challenging in post-transplant patients due to minimally dilated biliary radicals. Accessing the bile duct becomes further challenging in cases of cholangitis with cholangitic abscess, as the duct is collapsed and its walls are friable. After accessing the duct, attempt is made to cross the stricture, which is again challenging because these are fibrotic strictures. Drainage catheter is placed across the stricture, and balloon dilatation of anastomotic stricture is performed in multiple sessions. And normally in our institute, we do it every 2 to 3 weeks, and it is continued for 2 to 3 sessions. And after 2 to 3 sessions, the patient is sent for a ERCP stent placement via rendezvous procedure. And I'll just show you how we do it. This is one of the cases in which you can find this is the left lobe graft with a biliary stricture over here. PTBD has been done, and after PTBD balloon dilatation is being performed, because this was a left lobe graft and HJ was done in a pediatric patient. This is the site of stricture. The balloon is being inflated. And after successful dilatation, you find a free flow of contrast into it. There is no stricture seen. The caliber of the intrahepatic biliary radical and the anastomotic site is almost similar. And this actually confirms the resolution of stricture. And you can see one of the difficult case here in the MRCP. You can see there is just mild dilatation, central dilatation. There is a segment loss over here, and the peripheral duct is minimally dilated, and we don't see any dilatation in the periphery, which was not appreciated on ultrasound. So these are challenging cases, and it needs a lot of efforts to get into such a non-dilated system. And you can see this is the size of the catheter, and the duct is almost same. This is the duct size, and this is the catheter which has been inserted. This is the pouch from where we don't see any further communication. And normally, in case we are unable to cross the stricture, the patient is kept on external drainage for a few days, and a reattempt is done. Normally, if it is not possible on the day one, or the patient is having cholangitis, we keep the patient on external drainage till the time cholangitis is resolved, and this central dilatation also goes. That helps us in negotiating the wire across this stricture, and then a second attempt is made after 2 to 3 days. And on the second attempt, we were able to cross the stricture, and you can see this is the site of stricture. We are gone, and this is the point which I was trying to tell. Like, if you see the CBD in a post-transplant setting, definitely you will find that the size of CBD, this is almost a centimeter size CBD. So it is dilated. This mostly is seen because of denervation of the CBD in a post-transplant setting. So the treatment of anastomotic stricture is balloon dilatation, and it aims to normalize the bile outflow through the anastomosis, and the end point for ERCP or PTBD is lack of narrowing during occlusive cholangiography or free contrast outflow during the fluoroscopy. And clinical and laboratory resolution of cholestasis are the most reliable measures for successful treatment. And I'll show you one of the case. This is again one case where you can see this is the anastomotic stricture over here. Multiple session of balloon dilatation has been done, and this is how it looks. So if you see now, just compare with this image, you see that almost the duct size is very uniform. So after multiple session of dilatation, you find that the plasty leads to causes plasticity of the duct, and continued dilatation is seen, and there is no recoil. And then after that, what we do is a rendezvous procedure through which ERCP stent is placed. If it is the wire goes without a rendezvous, then the ERCP is done without a rendezvous. Else, what we do, we place a wire through it into the CBD, and through ERCP the wire is snared out, and over the wire the stent is placed. And this is the picture. This is how it looks after that. So coming to some of the data, this is one of the data from India. So this was about biliary strictures after endotherapy failure. But if you see what happened, it is a data of 932 live donor liver transplant patient, and 8.7% developed biliary stricture in 932, that is 81 patients. 75 patients underwent ERCP, and 6 patients had hepatococyginostomy. Right posterior sector graft recipients had the highest incidence. So in this study, they find that the right lobe graft or the right posterior sector graft had a higher incidence as compared to the left graft. And failure of ERCP was common among the patient who underwent ductoplasty. So all patients who had ductoplasty, the chances of failure was higher for ERCP. And PTBD was technically successful in 34 patients, so only 34 patients out of this 932 underwent PTBD, and the mortality rate following PTBD was 2.5% and morbidity was 15%. And for this, 5 patients in whom PTBD could not be performed were taken for HJ hepatococyginostomy. So this is again as per the different way of treating. Like first we go For ERCP, if there is a failure of ERCP, then PTBD is attempted, and finally, if nothing works, then hepaticojejunostomy should be taken for these kind of patients. Now, the other option is like placing metallic stent versus plastic stent. So this is a very controversial, whether a retrievable metallic stent should be placed or a multiple plastic stent should be placed for the resolution of biliary stricture. And this is one of the RCT which was published in gastrointestinal endoscopy. And again, they had two group of patients, like covered SEMS for 6 months versus multiple plastic stent placement, and multiple plastic stents were exchanged every 3 months during a period of 1 year. So it was prospectively randomized in 1:1 ratio, and median follow-up was 36.4 and 32.9 months for both the groups. And stricture resolution at last stent removal was achieved in 83.3% in the covered stent and 96.5% in the multiple plastic stent. And they actually concluded that covered SEMS are comparable with MPS regarding post orthotopic liver transplant biliary anastomotic stricture resolution. Covered SEMS allowed fewer procedures. So the only advantage of covered stent is fewer procedure, lower cost. Otherwise, if we see, then though not statistically significant, the placement of multiple plastic stent is as good or sometimes yield a better result as compared, but the patient would require a multiple procedure. So this is as per this particular RCT. Coming to a meta-analysis of RCT, so this is a meta-analysis of 4 RCTs comparing covered metallic stent and multiple plastic stent. And this included 205 patients, and again, anastomotic biliary strictures resolution and recurrence did not differ significantly between the groups. So in 4 RCTs, this meta-analysis showed that there was no significant difference between placement of a covered metallic stent and a multiple plastic stent. And the mean number of endoscopic retrograde procedures were lower for fully covered. So if we assume that there is no infection is happening while the stent is exchanged, then probably placement of multiple plastic stent would be a better way to go ahead in Indian setting, because multiple ERCP versus placement of metallic stent, the cost issue may be discussed. But sometimes what we see that every ERCP leads to some increase in chances of infection and cholangitis. That's why I may not agree with this particular meta-analysis, and I would say that if results are similar, then fully covered metallic stent may be preferred over placement of multiple plastic stents. So these are some, case reports just to show like what other alternatives are available. So this is a cutting balloon, that is a peripheral cutting balloon is available for resistant strictures. Mostly we have used and in 2 of the post-transplant cases, but that was for hepaticojejunostomy strictures, and which we published way back in 2016. However, in a transplant setting, in an anastomotic stricture, there is a case report for 2 cases where 2 patients with refractory anastomotic stenosis after orthotopic liver transplantation had a successful resolution. And this is how the peripheral cutting balloon looks, where you see there are 4 atherotomes which is mounted over a balloon, and it cuts the fibrotic strands and helps in better resolution of the strictures, though there are no larger studies to actually prove the efficacy. So still it is just we can try it in a resistant cases, but we don't know how efficacious it would be. Then coming to exciting new things, what is happening. So we do have biodegradable biliary stents for percutaneous treatment of post-liver transplant refractory anastomotic strictures, and this is one of the initial report which was published in 2020, and it said that percutaneous transhepatic cholangioplasty with a normal balloon was performed in all cases of anastomotic strictures. Refractory strictures which did not respond to conventional balloon dilatation were taken up, and polydioxanone made biodegradable biliary stent from Essex Ella biliary stent. So the same SX Ella stent which is placed, the same company makes this biodegradable stent as well. And 18 adult liver transplant recipients who developed a refractory biliary anastomotic stricture underwent biodegradable biliary stent placement after 10 months from the liver transplantation. After a median follow-up time of 27 months, complete resolution of anastomotic stricture was achieved in 72% of the patient with significant improvement on the liver enzymes. And the most important and the interesting fact with biodegradable stent is you just need a single procedure, single dilatation, you place a stent, forget it, you don't have to remove, you don't have to do a ERCP. It will be resolved over a time, and normally it gets resolved within 6 months, and that is the time which we normally take for metallic stent to be placed. So it's a very interesting thing to see. Though I have learned that it is available in India, and I think in another few months it will be available in Delhi as well. Let us see whether we'll be able to use it or not. This is another new design of biodegradable stent to improve management of biliary stricture, and it was used in pediatric split liver transplant, and it looks mostly like a plastic stent. This is how very different kind of a design you can see here. And again, it is used in the same way. The material is same. A PTBD has been done. Then balloon dilatation. After that, this plastic stent has been placed across it. This is how it looks, and this gets degrade. So even this study shows that 6 pediatric patients, 4 male and 2 female, underwent percutaneous stent implantation without complication, no non-clinical cholestasis during the median follow-up of 271 days, and stent dislodgement was seen in one of the cases. Because it is like a plastic stent, so definitely there is a chances of stent dislodgement, and in one of the cases we found, the authors found that there was a stent dislodgement. So it is important to identify the biliary anatomy which is unsuitable for primary ERCP and thus needing PTBD as a primary procedure, because all patients may not be fit for ERCP. So that is one of the important things, because those patients who are not fit for ERCP, they go for ERCP, and a failed ERCP may aggravate cholangitis and may lead to very different outcomes as expected. Similarly, it is imperative to formulate an algorithm to manage patients with a failed endoscopic biliary drainage with onset of cholangitis and cholangitic abscess, which I'll be discussing. And we recently had a paper also published on the same topic. And in this, a salvage PTBD, the patients who already underwent ERCP with failure or development of cholangitis or cholangular abscess were taken into consideration, and we found that there were 32 such patients with post-LT biliary stricture, bile leak presenting with deranged liver function in 12 patients, cholangitis in 12, and cholangitis with cholangitic abscess in remaining 8 patients. 20 patients had plastic biliary stents placed by ERCP, while remaining wire could not be negotiated across the stricture by ERCP. Immediate as well as sustained clinical and biochemical improvement was seen in 26, that is 81% of the patients, while failure of resolution and sepsis and death occurred in remaining 6 patients. And in this we had a pretty good outcome. And the most important point to note was the ductal anatomy at anastomosis is important to decide the appropriate approach for biliary drainage. And I'll be showing you some of the example. This is one of the case of biliary stricture. We don't see the CBD, although it is collapsed. That's why it is not see. This is one of the duct. So if we see carefully, so this is how it is going. And this is the picture. So a very zigzag kind. So even if ERCP is going to be done, first the wire getting up, then going down, and again getting up, ascending up. So sometimes it is pretty difficult while negotiating from below. And the ERCP was not possible. It was attempted, could not be done. Then the patient was taken for PTBD. We accessed this duct, the inferior duct, which was not nicely seen on the MRCP. And this is how it is being done. You can see the course of the wire. I just kept this image to show like what we saw. So if, although it is not projecting well over here, but it is seen like it goes like this. And that's why to make it easier to understand, I have made this overlay images to make you understand. And same has been shown like how the wire goes. But Once we cross it and we place a stiff wire for placement of a balloon, we see that there is a straightening of the stricture. And after the stricture is straightened, we place a balloon and do a balloon dilatation. Similarly, this is another case in which two duct anastomosis has been done. This was the cystic duct which was anastomosed, and this is the CBD which was anastomosed with the other duct. And this is the kind of anatomy, a very difficult anatomy. Again, this came from an outside center, and two ERCP were attempted at two different centers which failed. And after that, we did a PTBD for this patient. So these are difficult cases, and sometimes based on the imaging, we can actually understand like which is the case suited for ERCP or which is better suited for PTBD. Though ERCP remains the first choice, there is no doubt about it, but it is good if we can recognize the patients who would benefit from PTBD rather than ERCP by just looking at the images. This is another interesting case. If we see this case, it looks very simple, like this is a two duct anastomosis and this is the CBD. It seems as if both can be, but you know, once you take your wire and it cannulates this duct, it will always tend to go into this duct and will never take a lower course and then go like this. So this is a step pattern. The step pattern is again difficult to negotiate. So both the ducts cannot be negotiated very easily. It is not difficult, it is not impossible, but yes, it makes the procedure difficult, and with more difficulty, more use of hardware, and you know, extra time for maneuvering in a post-transplant patient leads to inflammation at the stricture site and may aggravate cholangitis and formation of cholangeral abscess. So these are important things which we should take into account. So with this, finally, I'll come to the algorithm which we had given in that paper, like how to go for management of biliary complications. So if we find a bile leak or a biloma, first we do a percutaneous drainage, and along with it, definitely there will be a stricture. So which I say that there should be a stricture unless until it is a non-anastomotic bile leak. Then if it is an anastomotic stricture, again we can assess it in a different way. If it is a non-anastomotic stricture, then you know, we can do a PTBD or ERCP, but at some point of time there will be a graft dysfunction and a retransplantation may be required in a non-anastomotic stricture. But as far as the anastomotic stricture is concerned, if we find a long and tortuous stricture or a stricture with sharp or acute angulation, it is better suited for PTBD. The highlight stricture with ductal separation, or there are multiple duct anastomosis, again it is better suited for PTBD, whereas single or two duct anastomosis with short segment smooth angle is better suited for ERCP, which is comfortable for patient as well. And if there is a failure to cross the stricture on ERCP, the patient can be taken for PTBD. If we are unable to do PTBD or we are unable to cross the stricture, then definitely hepaticojejunostomy is the choice what we should go ahead. So with this, I'll conclude my talk that biliary complication needs a special attention as it forms an important cause of prolonged morbidity and sometimes graft loss in liver transplant patients. ERCP is the first line of management for bile leak and biliary strictures, while PTBD is widely accepted for patients with complex or altered anatomy or hepaticojejunostomy. With the advancement in hardware technology and outcome of biliary complications have improved, and future remains exciting with increasing experience and availability of bioresorbable stents. Thank you all.